Good evening to all. My topic is treatment planning and evaluation for carcinoma cervix. Before start, I would like to thank the organizers and Dr. Kati from United Hospital for giving me this opportunity to talk to you on this great scientific occasion. So let us go into that presentation. So my presentation will be following these contents. Initially, as it is an educational program, initially I will talk about a little bit about the conventional treatment planning, which we were using based on two-dimensional information. Later, I will talk about 3D treatment planning, and then I will talk about IMRT and VMAT planning techniques as well as the optimization constraints. And later, I will talk about the brachytherapy and its role in the treatment of CS cervix. Because without brachytherapy, the treatment of CS cervix will not get complete. So, as you all know, cancer of CS cervix is one of the most common cancer among the women, especially in the Southeast Asia, and the huge amount of women were diagnosed every year with this cervix cancer. So as far as the treatment, radiation treatment is concerned for cervix, it consists of two parts. Mainly the external beam radiotherapy, which was delivered using either cobalt unit or linear accelerator. The other one is the brachy. So the brachytherapy nowadays in most places they were using high dose rate afterloader machine. First, let us see the external beam radiotherapy treatment technique for the CS cervix. So the external beam radiotherapy technique consists of three components. Initially, it was delivered using the conventional treatment, that is the 2D treatment technique. The latter, with the advancement of MLC, the three-dimensional radiotherapy has been evolved. And nowadays, most of the places, the high intensity modulated radiotherapy or volume modulated arc therapy is being practiced. So if you look into the split out, I mean the steps involved in the external radiotherapy, it starts with the positioning, preparation of immobilization and the simulation. Then it comes treatment planning and then selection of beam energy and then dose prescription and the treatment. So as the previous speakers spoke about the patient positioning and the simulation, my topic will be mainly on the treatment planning and the optimization techniques. So first let us see the conventional treatment planning technique which were used for the cervix treatment. So this slide shows the APPA technique which were initially used, I would say some 15-20 years back when I was working in a government institution. So this is an AP film which was taken using the simulator, and then here the main working pattern here is far as the landmarks are only bony landmarks. So if you see the superior border is L4 L5 junction, and then the inferior border is obturator foramen. And if you look into the lateral borders, it is almost 1 to 2 centimeters from the pelvis brim. This is how we will design the field for an APPA field. This slide shows the lateral field which was used for the box technique of using the conventional simulator film. So here also similarly the anterior and posterior borders are fixed based on the bony landmarks. So this is how the lateral field is designed in case of cervix in the conventional method. So, and another thing is in conventional treatment, as we don't have any MLC, we normally use the blocks for shielding the normal tissues. So this slide shows the corner shielding used in case of APPA field or in case of box fields used in the conventional treatment. So here the upper area was shielded for the bowel loops, and the lower part is shielded for the femoral heads. So this slide shows the shielding method used in case of lateral fields. And then this slide shows how the shielded field covers the nodal areas in case of anterior as well as lateral fields. So apart from this regular treatment, we also used to do the midline shielding in case of conventional treatments, because these midline shields were used to boost the nodal areas mostly after the brachytherapy. So we used to make customized blocks most of the times, or we use standard blocks. So if you look into the width of this block in the central area, it comes around 4 centimeter. So the intention here is to increase the dose to the parametrium. So this midline shielding technique will be used mainly for the cases which we are not able to do the brachytherapy, or which we are not able to do the template brachytherapy. But again, it has a controversial area. Some people will say that it may not be the appropriate method as it shields the primary area. So we also used to design fields for the irradiation of para-aortic nodes in the conventional technique. This is how the field will look like, and this slide shows the shielding areas of an anterior film. In the conventional technique also, we used to do both APPA field as well as 4 field. So this slide shows the comparison between the 2 field, I mean APPA and then 4 field box technique. Though those times we don't have the CT informations, we used to do the manual planning using isoghost charts. So now let us see about the 3D CRT treatment technique used in the CS cervix. So the main advantage of the 3D CRT is we will be using the CT images. So here we have the opportunity to contour the target as well as OARs, and we can use the MLCs or customized blocks to shield the normal tissues. And here we will use 2 or 4 or more number of fields in order to get the required field shape. So it has certain advantages, because here we can quantify the dose received by the OARs as well as the targets. And another thing is, when compared with the conventional, which we will be mostly doing point dose calculation, here we will be using a 3D algorithm, which will give the better results and accurate values. So as far as the contouring guidelines is concerned, there are many guidelines available for regional wise. This is an example I'm showing NIH recommended guidelines for contouring cervix as well as endometrium. So, but it varies widely because every country has their own recommendation, and it varies from department to department. And it is better, it is depending upon each institution to select the protocol for the contourization, which I am not going to talk in detail. Let us move to the aim of our 3D CRT. So like any other radiotherapy treatment planning, the aim of the 3D CRT is to give maximum dose to the target and minimum dose to the OAR. So as I told you, mostly for a pelvis patient, it's a golden standard using box technique, where we will be very rarely using more than 4 fields in case of 3D CRT. And as far as the energy is concerned, we will be using 10 or more 15 MV depending upon the availability. As the separation of the patient is expected to be higher in case of pelvis, so we will not prefer the 6 MV for pelvis irradiation. So dose ranges from 45 to 50.4 depending upon the stage, as per the treating consultant's choice. So if you look into the beam configuration used for this box, to 3D CRT, it varies widely. Like now, the most of the whole pelvis irradiation will be using APPA, and most of the times, as I told you, we will use box technique for the pelvis irradiation. And very rarely, in case of smaller diseases, we will use oblique fields. And in case of boost, we will be using a crossfire field technique, which helps to treat only the primary and to reduce the dose to the femur. Let us look into the details. So this slide shows the APPA field created using 6 MV photon field. Normally in our clinics we won't use, as it is an education program. I am just showing how the distribution will look like if we use 6 MV photon beam for pelvis. So if you look into that isoros lines, the maximum doses comes around 125%. So, and if you look, the parametry is not, not receiving adequate dose. If you use 10 MV for the same patient, the maximum dose will come down around 113%, but still it has some part of missing in the parametry. But if you go for 15 MV, we have significantly, 90% of the PTV is receiving the prescription dose. And if you look into the maximum dose also, it falls around 110. So this is the 15 MV photon beam will be used to most other places if it is available. So this slide shows the box technique normally used for the treatment of pelvis. So here the advantage of the box technique is it covers the nodal area as well as the PTV, but it reduces the dose significantly to the bowel area. So in this box technique, sometimes if needed to compensate the missing tissue, we will be using the wedges in case of lateral fields. Very rarely we will use the wedges in case of anterior fields. So if you look into the maximum dose, it falls about 103%. So there are certain things we have to consider when we do for a 3D CRT planning for the pelvis patient. So we have to use appropriate number of beams and use the collimator angles when required. And we have to, as I told you, we have to select the beam energy properly as per the patient separation. Use of beam modifiers or use of MLCs or customized block if it is needed. Adjust if you want to achieve uniform dose distribution, we can adjust the either beam weight or the wedge angle depending upon the patient contour and anatomy. We also has to select the wedge orientation depending upon patient anatomy in order to achieve the uniform dose distribution. Very rarely we may use field-in-field technique if you have very high hotspot inside the PTV. So this is very rare case, it's not very common. So if you look into the evaluation point of 3D CRT plan, it's like any other treatment plan. The dose, 90 to 95% of PTV should receive the prescription, 95% of prescription dose. Here, because of 3D CRT, we can accept up to 90%. Because as we have some limitations, we may not be able to achieve the 95% coverage. And all other OIR should get less than the tolerance limit as prescribed by the RTOG or any standard dose limits. So we have to look into the hotspot and what is the percentage of hotspot, where it is located, and what is the volume of it. And the hotspot ideally should be within the PTV, within the CTV preferably, and it should not be near any OIR. In the case of cervix, it should not be on the rectum or bladder, especially on the anterior part of rectal wall or lower part of bladder. And if there is a hotspot on the undesirable area, we may change the plan or we have to think of changing the modality. We also has to look into the monitor units, and the we have to look into the isodos lines, and each in all the three slices, and we can go down even 10% of prescription dose to see how the low dose was spreaded. So there are certain advantages of using 3D CRT. It has less EMU when compared with IMRT or VMAT. It has a faster delivery, and it delivers uniform dose to PTV as well as nodes. It doesn't have much of complexity like IMRT or VMAT. But the biggest disadvantage is it delivers the equal dose to the PTV. It delivers the equal dose to the ORs like a PTV, because it doesn't have any intensity modulation. So it also deposits the same amount of dose to the ORs. So to overcome this, the IMRT and has evolved. I mean, in the last 10-15 years, we have been practicing in Asian countries IMRT in most of the clinical sites. So in cervix also, we have started practicing the IMRT, and later we have started the VMAT also. So the main advantage of using IMRT for pelvis irradiation is we can use. I mean, it helps in reducing dose to the ORs. That is the main advantage, especially the low dose spread. So it helps. We can use single or multiple imaging methods. It is not necessarily we have to use only in IMRT. In 3D CRT also we can use it. So it uses a inverse optimization algorithm to create an intensity modulated distribution on the of desired pattern, and it uses more than 5 to 12 beams. In case of arc, we will be using 1 or 2 arcs, or sometimes partial arcs if needed. So the advantage is this intensity modulated therapy creates a customized dose distribution as per the patient's contour, and it reduces the dose to ORs, but at the same time it increases the MU. So here we have another advantage of increasing the dose if needed. So this slide shows the workflow of IMRT. It is like any other radiation therapy treatment. It starts from the beam placement or beam or arc placement, dose prescription. Then we have to give the dose constraint to the treatment running system as per the radiation oncology requirement, and as well as per the standard constraints for the organ at risk. Then we have to start the inverse optimization planning. We have to do multiple iterations in order to achieve the desired dose to the target as well as to the ORs. So this is the optimization constraints which we use in our institution, because we use the Monaco planning system. I am showing the constraints which we were using for the in our institution. So here the caution should be given to the patient or body, because this helps. But here we are using 3 layers of quartic overdose for the patient, because it helps us in reducing or in controlling the low dose area, because these optimizations, as we use multiple beams and arcs, so if we are not giving proper attention to the low dose area, it may tend to increase the low dose area, because most of the clinical settings we will not go down to 10% of dose and see. For example, if we are delivering 50 gray, we will not go down to 500 centigrade and see how far it is spreading. But this the different by giving stringent constraint to the body, we can have a control over the low dose spread in case of VMAT and IMRT. And many planners will be able to achieve the target dose. 95% will go to the PTV, but we have to be equally conscious about the low dose spread in the VMAT as well as in IMRT. So this slide shows the a 7-field IMRT plan generated for the CS cervix patient. So if you see the coverage, almost 96% of prescription dose is covered by 95% of volume, and the hotspot is around 107%, and if you look into the MU is around 9 or 2. The D2cc of rectum and bladder receives almost equivalent dose that goes to the PTV. So this dose volume histogram gives a comparison between a 3D CRT and an IMRT plan. If you look into the coverage of target, you may not find much difference between a 3D CRT and an IMRT plan. But if you look into the critical organs like bowel, bladder, as well as the head of femur, it has a significant difference. So this is what I was mentioning. The IMRT and the VMAT helps in reducing the volume, low dose volume doses going to the critical organs. So there are 3 points we remember when we do the IMRT and VMAT planning for the pelvis patients. As I told you, we have to use optimized number of beams or arcs. We have to, and another main thing is we have to give practically achievable dose consent to OARs in order to achieve a good desired dose, acceptable dose distribution. Because by knowing the rectum is very near to the PTV, we should not be very stringent on the rectal constraint. Then we may not be able to achieve the desired distribution, as well as the planning system will tend to spill the dose outside the PTV. So we also should have the thorough understanding about the optimization constraints, as well as optimization cost functions, how it works, because it helps us to use it appropriately. And if needed, we can use pseudo structure on the the dose which area which was deposited outside the PTV, or in order to control the dose to the OARs, it can be used. But most of the planning system doesn't require it nowadays, but some planning systems still needed these dummy structures. So apart from this, as in case of say a cervix, we most of the times we won't do SIB. We will try to deliver 50 gray or 45 degree in a single phase. So in this case, we can create an intentional intensity modulation by adding 1 or 2 gray to the CTV. Because if you allow the system to the intensity modulation, the distribution will be better. At the same time, we should have an eye on the low dose spread outside PTV, as I said already. So we also has to consider the uncertainty due to the setup. So this slide shows a VMAT plan generated for the same patient. So here we used 2 arcs using 10 MV. So here the maximum dose comes around 108%. So as far as the treatment plan is concerned, there is not much difference between between the VMAT and an IMRT plan, because only the delivery method varies, and VMAT gives us a little bit of freedom in escalating the dose. This DVH shows a difference just for a comparison between a VMAT and the 3D CRT plan. And then this slide shows the difference between an IMRT and a VMAT plan. So if you carefully look into the DVH, there is not much significant difference on the coverage in the PTV, but there is a small differences in the dose to the OARs, especially in case of rectum. So if in the VMAT, we have a freedom in escalating the dose. So that is why if you look into the VMAT, the rectal dose is lesser than the IMRT plan. So when we talk about the VMAT or IMRT plan evaluation, it is like 3D CRT evaluation only. But here we are very much bothered. We will not compromise on the coverage of PTV. Here the minimum requirement is 95% of PTV should receive 95% of prescription dose. All OARS should be within the tolerance limit. You all know very well what is the dose limit for bladder and rectum. But here we have to give importance. This target tolerance limits includes the brachydose as well. So if you are planning for a 50 gray, and if you look into the bladder constraint, it will be obviously less than the recommended value. but we have to consider it based on the 50 gray prescription. So then only we will be able to perform comfortably 2 or 3 brachytherapy in sessions. So like our 3D CRT, we also have to be very careful about hotspot and its location and how far its percentage is. So sometimes if the hotspot or low dose spread is outside the PTV, in case of IMRT, we may have to increase the number of beams, or we have to change the beam Gantt triangle or beam angle. And we also have to look into the number of MUs. And similarly, we have to see the dose distribution of the in all the 3 slices, and we have to see the low dose spread as well. So this slide maybe will give you an answer, because when it comes to pelvis, most of the people will ask what is a suitable energy to perform a pelvis IMRT or VMAT. So here this DVS shows the VMAT plan generated using 6, 10 and 15 MV. So if you look into the target as like other 3D CRT or IMRT and VMAT, there is not much significant. But there is a small differences in the OIR coverages, OIR doses. So we may have to do a separate study, and there are already studies available in the internet or in the scientific journals. So it is purely depends upon the institution policy, which energy they will prefer. In our institution, we'll prefer to use 10 MV for the pelvis patient. And in institutions where they don't have the higher energies, with 6 MV also they can perform the IMRT or VMAT for the pelvis patient. So this slide may give you a clear picture about the selection of photon beam energy for the pelvis irradiation. So now let us look into the role of brachytherapy in the treatment planning or in the treatment of cervix. So the brachytherapy, as you all know, is a modality where the radiation source was used to deliver the desired dose, and the radiation source was controlled by the computer, and it was delivered in or near to the target. So the main advantage is it has a rapid dose escalation. Still, it has a very strong role in the gynec brachytherapy. In most of the places, the brachytherapy is being practiced using high dosage brachytherapy. Most of the times, they are using cobalt 60 or iridium as a source. So this is a paper which was published in 2019. So this paper will shows a strong, I mean, the integral part of primary, the role of brachytherapy in treatment of primary cervix. So here they have compared the two group of survival of patients which were treated with brachytherapy and external beam alone. So the inclusion of brachytherapy in the treatment of cervix has a significant improvement on the overall survival of the patient. So though in certain parts of the places the role of brachytherapy and then brachytherapy applications is coming down, this paper clearly says the role of brachytherapy in the treatment of cancer, and it helps in increasing the overall survival significantly. So this slide shows the applicator widely used for the brachytherapy treatment. So one is a Fletcher-Williamson, other one is a ring applicator. So this slide shows the conventional orthogonal films which were being used for the treatment of brachytherapy. So this is a conventional orthogonal X-rays acquired with 90-degree apart. This is the anterior film and this is a lateral film. This shows the reconstruction of catheters and the distribution. So here and bladder and rectal points were marked based on the ICO recommendation. And the biggest disadvantage of this method is here it only gives the point doses that has been received by the OIRs. And when compared with the 3D CRT and external beam, it is very difficult for you to take a decision because this external beam will give the volume doses. But here we have only the point doses. So in order to overcome this, later the CT-based brachytherapy planning has started. So in the CT-based brachytherapy planning, we will be using the CT slices for the reconstruction of applicator as well as the planning purpose. So I'm just taking you through the process of brachytherapy CT-based planning. So we are in the first step where we will be taking a CT scan of the patient after insertion applicator, and we will be drawing all the OIRs, bladder and rectum. Then we will be reconstructing the applicator using axial or sagittal images. So this slide shows the reconstruction of brachytherapy applicators. Later, we will be defining the point A and point B in the CT images. Then we will be loading the radiation sources in the applicators to generate the radiation dose distribution, and then we will be prescribing dose to the point A. So the advantage of this method is we will also use to measure the width and length of the isotope lines, that is 60 gray volume. So the main advantage of this method is we will be able to quantify the radiation. I mean, we will be able to quantify the dose to the OIRs, and we could be able to measure the D2cc doses received by the bladder and rectum, which will help us to add the external beam and take a decision whether we may need 2 or 3 fractions for this patient. So this slide shows the American brachytherapy recommended and as well as the ICRE 89 recommended dose limits for the OIRs as well as the point A. So the D2cc bladder should be receive less than 90 gray, and it is an EQD. In the latter, I will tell how the EQD can be calculated using external beam as well as brachytherapy doses. And the rectum dose should be less than or equal to 75 gray of EQD2. There are certain points we have to concentrate as far as brachytherapy treatment planning is concerned. So as far as recent Saffron report is concerned, they have reported more than 500 accidents happened only in the HDR treatment modality, and most of the things are happened due to the manual errors. So when we do the brachytherapy planning, we have to give caution, or we have to be very keen on certain steps. It includes using of appropriate activity or using the correct source for the particular unit, especially when you have 2 units in your institution. And we have to enter the correct reference length for the applicator used for that particular application. And we have to construct the applicator properly as per the commissioning details. We have to, in case of CT planning, we have to apply the offsets as per the vendor recommendation, and we have to load the radiation source in a pattern to us, because in brachytherapy we are not doing the HDR brachytherapy, we are not doing HDR. We are trying to mimic the LDR loading pattern. So the source loading pattern should be proper as per the recommended pattern, both in intrauterine cube as well as in the tandem. Both in ovoid as well as in tandem. So we also has to pay attention in placing a reconstruction point A, and we also has to place the ICRU point as per the recommended method. And it is highly recommended to go for a secondary check as well as the checklist. So this is the radiation source loading pattern in case of Electa HDR, and this also shows the loading pattern in both ovoid as well as in the tandem for HDR using iridium 192. So this will help us to in creating the pear-shaped isotope line in case of CS cervix. So this slide shows the dose fractionation scheme recommended by American Brachytherapy Society in combination with the external beam radiation therapy. So most of the institution, the problem what they will face is when we are adding the HDR dose along with the EBT, they may have some difficulty because the dose rate as well as the treatment time varies between these two modalities. So there is a LQ proposed model available in the journals, but this is a spreadsheet given by the American Brachytherapy Society where you can enter the number of fractions external beam radiation details as well as the desired your preferred dose per fractionation for HDR brachytherapy. This will finally will give you the what is the overall treatment EQD value, EQD2 for the particular patient. So which we can use it in our clinic easily and readily, and it will help us to in reducing the errors. Similarly, the same ABS also has given a Excel worksheet for calculating as well as recording the dose to the ORs as well as to the targets. So this will help us to record the details in a unified method for all the patients, and also it helps us to decide how many number of fraction brachytherapy may be required for this patient. In summary, I would like to say that we have to use the proper combination of external beam and brachytherapy combination in order to achieve the overall outcome of the CS cervix. And when we were planning the external beam and brachytherapy, we have to consider the radiobiological point of view in reducing the overall treatment time, because it should not be more than 8 weeks. And when we think of brachytherapy, we should go for minimum 2 to 3 insertions as per ABS recommendation. And as far as cervix is concerned, we Asian people has a vast experience and more number of patients when compared with Western world. So, and we have the huge experience as well. So when we use the modern tools, we should use it with caution. So with this, I am completing my slide. I would like to thank the organizers for giving me the opportunity once again, and I would like to extend my thanks to Karthik and my colleague Masurana who helped me in preparing the slides. Thank you. Thanks a lot.